Hello, everybody. This is Andy Stein at Boston Medical Center. And this next talk will be on CMC arthroplasty of the thumb, where we are in 2020. I think I'll stop the video so we can focus on the slides. And so again, this talk is about basal joint arthritis, which is, as you all know, is a very common problem. It's thought to be basically an inevitable part of aging and being human, especially in women who tend to present earlier in life than men. But what we do know is that most people that we see who present with basal joint arthritis can adapt and cope well with this. So the factors that are associated with people presenting for treatment remain somewhat uncertain, but we think they're most likely include a lot of psychosocial factors and coping issues. Radiographic criteria alone is never an indication for surgery. And that's a very important point because we don't treat x-rays, we treat the people. You have the worst x-rays in the world, doesn't mean you need an operation. The extent of the problem is pretty large, as I mentioned. In this study by Armstrong back in the 90s, they showed that in people over the age of 75, the prevalence of radiographic arthritis at the basal joint was 40% in women, 25% in men. And it remains the most common surgery that's done for arthritis in the upper extremity in the US today. More recent paper by David Ring's group and in conjunction with a group out of the Netherlands showed that the prevalence is probably higher than that Armstrong paper suggested. And you can see in this study, they looked at patients presenting with distal radius fractures to an ER, and they looked for radiographic evidence of CMC arthritis. And you can see as you got older, it's a straight line right up. In the women that were 90 plus, it was almost 100% incidence of radiographic arthritis. So again, it's thought that if you live long enough, you're basically going to get arthritis, but that doesn't mean you're going to need something done about it. And in fact, in this particular group of patients, there was only 3 people in this cohort that had had surgery on their thumb out of over 2,000 that they presented. Just as a review, I remember the staging that we use for basal joint arthritis was described by Dick Eaton and Steve Glickel. It encompasses 4 stages. Stage 1 is where patients present with pain, but no real arthritic changes, maybe some widening is thought of the joint from synovitis. Stage 2, there's narrowing of the joint with small osteophytes, which progress to stage 3 and 4, where there's pantrapezial arthritis. In terms of treatment, non-operative treatment remains the standard of care for most people. Splinting is the top of the list of what we usually start with these patients. Again, what you use probably depends on where you practice and your preference, but there are at least 2 randomized studies in the literature shown here where patients seem to prefer short neoprene splints over rigid splints. And so I'm not sure what everyone does in their practice, but starting with a short, soft neoprene splint is not a bad way to go, as it seems to be more cost effective and is preferable, at least in these studies, by most patients over the rigid splints. In addition to splinting, injections is also a mainstay of early treatment. We do a lot of cortisone injections where I am. It's been shown that the best efficacy seems to be in the early stages of OA, where it can usually last up to maybe 3 months. Some people seem to get longer or shorter periods of relief. In these 2 studies, patients still having pain at a week seem to correlate with progression onto surgery. And in this cohort that they looked at, about 30% of the patients progressed to surgery at a mean of about 8 months. So it's certainly something to try. Once there's arthritis, the horse is out of the barn. We don't really think there's any downside to it as long as you use sterile techniques. So we use this quite a bit. It's also, like with carpal tunnel, can be predictive in terms of who's going to get good relief after surgery. If they have arthritic changes and you inject them and they don't get relief, you think twice about offering them surgery. Where we do a combination of doing it with just using local landmarks, or occasionally we'll use radiology using ultrasound guidance if they don't get good relief with the first injection, just to be sure that we're actually in the joint. In terms of Synvisc or hyaluronate, people have been using this. It's currently considered off-label use, at least in one study that by Hayworth about 10 years ago, they compared this to steroids, and they showed there was no benefit as compared to steroid injections. So it's more expensive, and given that there's no good evidence that it's any better, I personally don't use it, but I do know that some people are still using it as an off-label use of the drug. The other thing that's gained traction or is becoming a little more popular recently is PRP. Like most other areas in orthopedics where PRP is used, there's really no good data that it works that well. I mean, this is a more recent study here a few years ago where they injected patients twice 4 weeks apart and followed them for 6 months. It did show some decrease in their pain scales, the VAS, the Mayo risk scores, but there was no change in the DASH, and they actually demonstrated decreased pin strength, which is hard to explain. So PRP is certainly something that you can try or that people are using, but there still isn't good published literature that it's any better than cortisone. Therapy, in addition to splinting, OT has a growing role that's actually been documented. Julie Adams' group at the Mayo Clinic showed, at least radiographically, when you activate the first dorsal interosseous muscle, it seems to reduce the CMC joint, which may help with patients who are having pain from arthrosis. The other thing OT usually focuses on is increasing mobility of the CMC and MP joints of the thumb, as well as strengthening the thenars, interosseous muscles. And in a systematic review a few years ago, Abisher showed that it actually helped pain and quality of life in addition to this multimodality treatment with splinting and strengthening. So there seems to be a growing role and indication for therapy in addition to just fitting people with the proper splints. In terms of surgery, the history of surgical management dates back to the 40s, where the first published series was by Gervis, where they had reported in 18 thumbs where they did simple trapeziectomies and showed good pain relief. Over time, this progressed to the 70s, where Bill Littler and Dick Eaton in New York started adding volar ligament reconstructions with or without partial or complete trapeziectomies, and ultimately ended in the 80s with Burton and Pellegrini publishing their landmark article about ligament reconstruction, tendon interposition, or LRTI, which really has been sort of the gold standard for the last half century. This is a picture on the right, shows what's done with an LRTI procedure where you do a trapeziectomy. You borrow either half or all of the FCR tendon, pass it through a drill hole in the first metacarpal base for a suspension of the thumb metacarpal, and you use the remaining FCR tendon as an interposition material in that space created by the excised trapezium. So the LRTI procedure is what I learned as a resident, as a fellow. But again, as we'll talk about as this talk goes on, it's no longer maybe the best way to go. In terms of simple trapeziectomies, the advantages are it's very simple surgery. Roy Meals in California brought it back in 2003 when he published his series of so-called hematoma distraction arthroplasty, where he did a simple trapeziectomy and then distracted the thumb metacarpal and pinned it with a K-wire to the second metacarpal for 5 weeks. And he showed excellent pain relief and good functional outcomes, even at 6.5 years. Salem and Davis out of the UK also published on a series, and they compared this to LRTI group and showed no difference in pain, pinch or grip strength at 6 years out. However, if you follow that same group of patients by Salem and Davis further along, what they showed a couple of years later was that they were able to demonstrate arthritic changes in 7 out of the 25 patients that had simple trapeziectomy, where they only saw arthritic changes in 1 out of the 29 patients that had an LRTI procedure. And the height of the pseudoarthrosis was lost in the simple trapeziectomy group at a greater rate than it was in the LRTI group. So again, no one's really sure. At least in the short run, it seems that simple trapeziectomy may be as beneficial, but as you follow these patients out, the loss of height and arthritic changes may get worse. So it's still somewhat unanswered question. This is what we most fear with simple trapeziectomy alone, which is the so-called collapse or Z deformity of the thumb, where you can see the first metacarpal subsides, starts to dorsally subluxate, and then the MP joint hyperextends to compensate, and it leads to progressive adduction contracture of the thumb and first web. And this is why a lot of people think suspension of some kind is better than a trapeziectomy alone. So in terms of suspensionplasty, many different techniques have been described. The Wildby technique uses a slip of the APL tendon, which is wrapped around the FCR tendon, as shown in this picture here. And again, most of the published studies on this, as well as using the FCR tendon, such as in the LRTI procedure, have shown excellent pain relief and excellent function. But even with suspension techniques using tendons, subsidence tends to occur. But in these published series shown on the bottom right, it doesn't correlate with outcomes. So suspension, at least in theory, seems to be beneficial. Again, as I mentioned, the LRTI procedure still remains the gold standard for this surgery. In this published series in 1986, Burton and Pellegrini showed at around 10 years out, there was a 92% increase in grip strength and a 50% increase in tip pin strength. 95% of the patients reported excellent pain relief. And they did show about a 10% loss of arthroplasty height as compared to where they were immediately post-op. The bigger issue is that complete recovery in this group and in most people's series usually takes at least a year or more. So it's a relatively slow recovery, which is one of the knocks on this. Again, in terms of even early on, the recovery is relatively slow. The authors recommend immobilization for at least the first 2 to 6 weeks and deferring any kind of strengthening for at least the first 3 months. The other problem from a surgical point of view is that this is a technically demanding procedure, which can often take upwards of an hour to an hour and a half. The reason it's technically demanding is you're drilling a hole through the metacarpal base and trying to pass the FCR tendon through that, which can be difficult. If there's poor quality bone, you can blow the bone bridge apart. And it's also very difficult sometimes to set the tension right. So it looks great in images. And in fact, if you do it right, it's a great operation, but it's time consuming and technically demanding, which is why I personally don't do it anymore. Just to be complete, implant arthroplasty is another option that's out there. The first implant that was available was silicone by Al Swanson. This evolved into metal and polyethylene and pyrocarbon. Most of the published results are mixed with usually around 25 to 30% failure rate, which is usually due to loosening or dislocation of the prosthesis. The best published data is from Norway, where they showed a 90% survival at 10 years and around 500 implants, and there didn't seem to be a difference between silicone or metal and polyethylene. But this seems to be more popular in Europe than it is in the US, where people are concerned about the need to revise these or failures. So it's done here, but not as frequently as it is in Europe or other places. What about fusion? Historically in this country, it was indicated for laborers or young patients, and it works well, but the biggest problem is non-union. Most recently, Vermeulen reported in JBJS on a randomized controlled trial comparing LRTI versus fusion in women over 40. And they showed that there were similar outcomes in terms of patient-reported outcomes, but they terminated the study early because the complication rates were so much higher in the fusion group. They had about a 20% non-union rate. So assuming you get these to heal, they do just as well, but there's a high complication rate, and since there's no inherent benefits, this is also fallen by the wayside by most people. Just doubling back to that hematoma distraction arthroplasty study by Roy Meals. Again, this is where they did a simple trapeziectomy, and then they distracted the thumb and pinned it for 5 weeks, and they showed pretty good results, as shown here. But over time, as they followed them out, there was a progressive loss of that space, arthroplasty space, which we think may correlate with progressive arthritis in the future, as well as that Z deformity. But the take-home message from this procedure is that trapeziectomy combined with preservation of the arthroplasty space for some adequate amount of time, and in that group it was 5 weeks, seems to result in outcomes that are consistent with the more complicated procedures. So as long as you remove the entire trapezium and keep the thumb out to length long enough, that area will scar in, and patients seems to do pretty well in terms of pain relief and reasonably good function. But again, in Roy Meals' group, they were using K-wires, which in my experience are not well tolerated. They're associated with a lot of discomfort, possible pin tract infections, which is why some of these newer suspension techniques have caught on. And to be complete, we'll just briefly talk about what these new suspension techniques are. The first would be suture suspension, second is suture anchors, and third is suture buttons. So suture suspension is what it sounds like. You use a heavy non-absorbable suture. In this case, Peter Weiss's group used a number 2 fiber wire, where you basically pass the suture between the APL and the FCR tendons, and you're basically creating a sling of fiber wire sutures, which supports the first metacarpal. And in this group, they showed pretty similar outcomes to the LRTI group, as well as the distraction hematoma group. Suture buttons do the same thing. So Arthrex makes this mini tightrope, which is very popular in some areas. Basically, it's the same idea where instead of a K-wire, you're using this mini tightrope device to suspend your first metacarpal out to length. And last would be a suture anchor with internal bracing or labral tape, which is the same concept, but you're using labral tape with suture anchors at the base to keep the thumb metacarpal out to length. Briefly, I don't want to dwell on it, but this is personally what I've switched to in the last 2 years or so. Just take you through real quick. The way I do it, I use a dorsal approach, seen in the upper left here. Allows you to go in between the tendons in the first compartment, which protects the branches of the radial sensory nerve, which are most at risk with this approach. You can then see you can fully excise the trapezium, either piecemeal or with some of the podiatry elevators, you can pop the whole bone out. And then you basically put your suture anchors with labral tape into the second metacarpal base and then dock it in the first metacarpal base. You can also add a piece of tendon graft if you want to make it more biologic. But again, based on those other studies, the thought is as long as this doesn't fail in the first 5 or 6 weeks, you should get the same outcomes. And this is what it looks like at 6 months out in one patient, where you can see that first, that space is maintained where the trapezium was. We like to see the first and second metacarpal bases resting at the same level with each other. So again, this technique is relatively simple. Once you get comfortable with it, it only takes maybe 15 or 20 minutes to do the surgery. So it seems, at least in my hands, a lot quicker and simpler than the LRTI procedure, which is why I personally favor it now. In terms of rehab, again, with the LRTI procedure, people were placed in spica cast for the first 2 weeks. They were only allowed to start gentle motion at 4 weeks, and they were maintained in some kind of orthosis for at least the first 2 months. And strengthening was really deferred until 10 weeks, and unrestricted activities were deferred until 3 months out. So it was relatively slow progression postoperatively. And again, as noted in a lot of these studies, it would take most people about a year to really reach end result from this. The newer accelerated rehab techniques with either a tightrope suspension or the labral tape suspension are much quicker. So you can see this is Jeff Yao, who's out at Stanford. He favors the tightrope suspension technique, and what they do in their group is they keep them immobilized post-op for the first 7 to 10 days and then switch them to a custom orthosis. At 2 weeks, the patients are encouraged to do light activities without the splint. And at 4 weeks, they can discontinue the splint except for nighttime use, and they start light strengthening. And at 10 weeks, they DC all splints and can start unrestricted activities. And again, they seem that it was relatively cost savings because they would only be seen 5 or 6 times on average in that group. My personal rehab, I can simplify it here, is I usually immobilize them in a splint post-op. I see them back usually 10 days where the therapists see them and make them a custom hand-based opponent splint. We actually encourage them to start immediate full range of motion exercises of both the thumb ray as well as the MP joint, and they can do light pinch even picking things up. We just encourage them not to do tight pinch. At 6 weeks, we really start progressing them to strengthening with a putty. And I try and hold off from heavy weightlifting or full activities till 12 weeks. But it's definitely a much more accelerated rehab program than what we used to do when we did the LRTI procedure. So in terms of conclusions, remember that arthritis, this first CMC joint, is basically a part of being human. Most people are able to cope with this, but when surgery is felt to be necessary for whatever reason, everyone agrees that trapeziectomy is indicated, but there's no clear consensus on what other procedures should be used to augment this. First, metacarpal subsidence has been shown to lead to a failure of simple trapeziectomy alone, which is the rationale for using some sort of either ligament or artificial suspension techniques. Personally, again, I prefer internal suspension plasty because it avoids the inherent problems that can be seen with K-wires, such as pain or infection. And I also favor this because it's quicker surgery with less morbidity, accelerated rehab, and it seems to have increased patient satisfaction. So there we are. I think we're right on time. It's around 20 minutes. And even though this is a pre-recorded talk, I think we'll have time to have some discussion now and take questions. So thanks.